This meeting is being recorded.
Getting a little bit of feedback on the line. Good evening, everyone. You're very welcome to this evening's webinar. Thank you for joining us. If you could just ensure that you're muted when you join the webinar, just so we don't get feedback on the line. Thank you. Okay, so we'll get started and we'll put up our introduction slides. Thanks, Audrey. Thank you, Audrey. So this evening, our webinar is on the topic of endometriosis and thinking about some of the pharmaceutical care issues in relation to that. I suppose thinking about pharmaceutical care, some aspect of that topic is thinking about what we as pharmacists, community pharmacists, perhaps in particular, can do to assist our patients who have endometriosis or think they might have endometriosis. Hopefully you have joined us for webinars in the past, but if you've not, just in terms of the domestics, as I said, it would be great if you could keep your microphones muted for the duration of the webinar. You can keep your cameras on or off, whatever you wish, but if you're experiencing connectivity issues, it might be best to turn off your camera. If you're having any technical difficulties, it might be best to leave and rejoin the webinar. And Audrey is sitting here in the background as well to assist with any technical issues that you have. We will welcome questions, of course, but we might keep them for the end of the presentations this evening, if that's okay. But if you have a burning question, please do just, and you think you might forget it, please do just type it into the chat box and we'll get to it towards the end of the webinar. And we'll circulate a feedback survey towards the end of the webinar as well. So turning to our speakers then, introducing our speakers this evening, I'm delighted to be joined by Kathleen King, who's an endometriosis advocate and who's a senior medical laboratory scientist with the HSE, and Elaine Bird, who's also an endometriosis advocate and senior pharmacist with the addiction services with the HSE. And I know there's been a lot of media coverage in recent days in relation to this topic, and I think it's particularly timely that we have scheduled this topic now, but obviously this is a topic that has been long overdue and long sought for by pharmacists who've been attending the IOP webinar event. So I'm delighted we can get to this topic now. So our first speaker will be Kathleen this evening, who will share her slides in a moment.
Mary Claire, just lost you there.
Yeah, I'm still here, Kathleen. Can you hear me?
Okay, I can hear you now.
Yeah.
Perfect. Are you ready for me to go ahead?
Yes, please, if you could. Yeah, thank you.
Thank you. Okay, good evening, everybody. And I'll apologise in advance for the poor lighting, and I will have to turn off my video as well too, because the connection here is quite poor, so bear with me.
That's great, Kathleen. Thank you.
Now, just first of all, I want to thank the IIOP and everybody who has come along tonight. Audrey and Mary Claire have been absolutely fantastic. And myself and Elaine tonight are going to take you through a very quick talk on endometriosis, and we're looking forward to the questions at the end of it. So as Mary Claire has introduced there, like, I am a medical scientist. I've lived with endometriosis and adenomyosis for a long number of years. And this has led me to become an advocate. And if that wee girl on the side of the screen there had have known what was ahead of her in life, she might have chosen a different condition than endometriosis. But it turned her into a fighter, and here we are tonight. So we know from the media coverage recently that endometriosis has become a very hot topic in Ireland this week. And we have 155,000 women estimated in this country with the condition. Now, the literature is predominantly around women, and this term is not designed to exclude anybody who doesn't identify as a woman, or we also have some trans men who are living with the condition, and also a very small number of cis males. But for the purpose of this presentation, a lot of the literature, we will use the term women. But again, it's not designed to exclude. So if we think of 1 in 10, if you think of 10 women in your life, you're bound to know somebody with endometriosis. So when we think about endometriosis, you often hear it described incorrectly in the media. And it's one of the biggest frustrations, I think, that I have. And why is it so important that we get this definition right? So when we think of endometriosis, it's a chronic inflammatory disease due to the presence of endometrium-like tissue outside of the uterus. Now, the misinformation is nearly always around what the lesions actually are. A lot of people think it's the same as the endometrium, that the endometrium flows back out through the fallopian tubes and falls in the pelvis. But unfortunately, that myth has caused so much damage over the years. We know that when we describe the endometrial-like tissue as the endometrium, we lead people to believe that a hysterectomy or removal of the ovaries may actually be a cure for this condition, when we know that it isn't. The endometrium-like tissue behaves completely differently. It's able to form its own nerve supply, its own blood supply, and it even is able to generate aromatase, which in turn can produce estrogen in its own area. If it was as simple as the endometrium, simply taking away the uterus should end the problem. And unfortunately, many women have been castrated over the years. Many women have been left with their organs removed at a very, very young age, needlessly. So I think it's very important to understand the definition. And endometriosis has been linked to periods, it's been linked to menstruation, it's been linked to everything around the cycle. And while the menstrual cycle does have a huge role to play in this, in terms of exacerbation of symptoms and in terms of how the woman actually feels herself, there's also a wider concern to this as well. We certainly feel now in this day and age that it's more of a systemic condition. It's more of an inflammatory condition that affects almost every area of the body. And interestingly enough, endometriosis lesions have been found in every area of the body itself. Up until I think it was maybe last year or the year before, the spleen was the only organ that was not affected by endometriosis. And this has now been published as a case study. It's an absolutely fascinating disease. Unfortunately, there's just not enough people studying it at the moment. So normally when I talk about endometriosis, and I usually get the sort of eye glaze and people go, oh, that's just period pain, and how bad can it be? You know, and if you're listening to Joe Duffy this week, you will have heard the horrendous stories that, you know, women have gone through, and the delays in diagnosis, the absolute nightmare that they've had. And you have to remember in Ireland that the average delay to diagnosis is 9 years. But I've seen women at the extreme ends of that. I've seen women 20, 25 years suffering, going back to their GP time and time and time again to try and get a diagnosis. And when you look at all these symptoms on a list, you think, okay, that is a little bit vague. There's an overlap with a lot of other conditions. But if you start to talk to women and you start to listen to them and you start to understand what they're saying, this level of pain, this level of debilitation, and these level of symptoms cause you to miss out on life. These are the type of symptoms that stop you going to your best friend's wedding. They're the type of symptoms that cause you to miss out on school. They cause you to miss out on college. They cause you to miss out on work. And they're life-changing symptoms in many cases. Often young women are prevented from following maybe a career that they would love to do as a result of missing so much school, or what we term as presenteeism, where they're physically there, but because they're in so much pain and they're in so much suffering, they're not able to concentrate and they're not able to focus. So if we think about endometriosis and we think about all these symptoms, you know, the first one, the quite obvious one that we nearly all identify with it, is pain around menstruation. For a lot of women, this is how it starts. The symptoms can start prior to the very first period. We have reports of very young women being sort of in and out of ED and in and out of their GPs with non-specific abdominal pain or presumed appendicitis, which then later on, when they're diagnosed with endometriosis, they're able to tie that back in to their first period. This pain can be very, very severe and, you know, completely debilitating. For a lot of women, this progresses on then to like that non-menstrual and, you know, pain that's pretty much 3 out of the 4 weeks, if not 4 out of the 4 weeks of the cycle. And one of the topics too that we don't like to discuss quite often, and certainly I've been chastised for talking about it in sort of polite company, is painful sex. And this isn't just, straightforward, pain with sexual activity. This is pain for some women on arousal, pain after orgasm, pain with any sort of sexual activity at all. And you can imagine that's actually not quite a nice symptom to have. And it's something that, leaves women very embarrassed, and they find it very hard to talk about as well. Infertility is the one that gets a lot of the media coverage. And, rightly so, 50% of those with infertility can live with endometriosis. And endometriosis, those who live with endometriosis, 30% of them may never conceive due to the condition as well. With infertility, it's one of those ones we don't really know how it causes infertility. We do know that it has an impact on egg quality. The inflammatory process as well too can help block conception. There's obviously physical inhibition there of conception with regards to maybe your ovaries are stuck to your bowel or your fallopian tubes are blocked with adhesions. And then we know that women with endometriosis also have anovulatory cycles. But in a lot of cases, we're not actually able to pinpoint why they can't conceive. Often it's a combination of factors. One of the other symptoms that I know when I speak to women that they're absolutely devastated with is fatigue. And this is very debilitating when it comes to being able to live your life and get on with it. We can maybe survive on medication for a lot of other things, but when it comes to fatigue, this is the bone tiredness. This is the thing that you can't shake. This is something that a good sleep or an iron tonic is not going to pick you up from. And again, I think, we've such little evidence around this, but this nearly seems to come from that systemic inflammatory, your body is fighting this process. That on top of fighting a huge amount of pain as well. A lot of cyclical intestinal complaints. You're going to see a lot of women with IBS diagnosis, a lot of women with bowel issues, be it a lot of diarrhea, constipation that's worse around the time of the period. Some women with rectal bleeding as well, which comes, worse around the time of their period too. That's, often misdiagnosed as piles or maybe rectal fissures. We have women with painful urination, again, worse around the time of their period, or women who get a lot of blood in the urine, which is often, again, misdiagnosed as a UTI. And you'll find that women will tend to track something like this. They tend to get the dipsticks and keep an eye themselves on, what level of blood is in the urine at what times of their cycle. I know a lot of women are very tuned into that because they're very conscious of kidney loss, and kidney loss is a real risk with some women with endometriosis. One of the ones that throws a lot of people is cyclical shoulder pain. And this is, again, because endometriosis doesn't just affect the pelvis, it can affect the diaphragm, it can affect the lungs, it can affect, some of the nerves around the diaphragm as well, too, that progress up towards the shoulder. So as you can see, when you're faced with this huge amount of symptoms, that it can be very, very hard when you're sitting down in front of somebody, to make a diagnosis. And when I throw in this additional list of symptoms, certainly my GP colleagues are just overwhelmed. They're like, okay, enough's enough. But when you start piecing all these things together again, think of the woman in front of you, think of that holistic approach to this. Are these symptoms enough that they're going to make you change something about your life? So you're not going to be able to attend an event, you're not going to be able to progress in something in your career, progress in something at school. And again, too, a lot of these symptoms are symptoms that women are going to be presenting, especially into community pharmacies with, for like migraine medication, or like maybe looking for something to help with vaginal fungal infections. Again, too, you've got a lot of mixed symptoms here that we don't have enough research on to tie them back, but these are commonly reported. So the diagnosis and treatment of endometriosis, this is a huge area, and this could be a whole talk on itself. But to diagnose endometriosis effectively, laparoscopic surgery is needed. Now, I've been part of the ESHRE guidelines, and one of the things that was published in the most recent guidelines was that laparoscopic surgery is no longer the gold standard, that we can now use imaging to diagnose endometriosis and stop the clock in terms of the delay to diagnosis. This sounds absolutely fantastic until you realise that the use of MRI and ultrasound, in particular in Ireland, is not sufficient to do this. And many women are turned away with a negative diagnosis and again, forced to think that this condition is back in their heads. So for now, we still find that women do need to progress towards surgery with an experienced surgeon to receive a diagnosis. Unfortunately, while most gynecologists should be trained to recognise endometriosis, it can be very, very tricky to recognise it in all its forms. Imaging can certainly be helpful. It can be helpful in identifying maybe large endometriomas, which are cysts on the ovaries. It can be maybe useful in identifying large rectovaginal nodules and help preparing for surgery. But imaging should never, ever be used to exclude endometriosis. And again, we're back to listening to women. If somebody is complaining of deep dragging pain, if somebody complains of painful intercourse, you can't see anything on imaging, you still need to investigate. When it does come to treatment of endometriosis, one of the main things that we see in Ireland is ablation. And ablation of anything is to burn it. And when you burn the lesions of endometriosis, you're never sure what you've done. And this is the sort of lab side in me coming out. I like to see the use of excision. And the use of excision for endometriosis ensures that when you take out the lesion and give it wide margins, that it can be sent to the lab, the pathologist can have a look at it, and we give some reassurance back to the patient and the surgeon that the endometriosis tissue has been removed in its entirety. Now, endometriosis surgery is incredibly difficult. It is not for the faint-hearted, it is not for the unskilled, and certainly it is something that needs a lot of additional training and a lot of interest. Endometriosis routine ablation surgeries can be 15 minutes long. Endometriosis excision surgeries, where you remove every single lesion and divide any adhesions that are there and make sure that the woman is, more or less clear of all the disease, can take 6 to 8 hours in very complex cases. So as you can imagine, it is quite a complex surgery. And at the moment, we are reliant on laparoscopic surgery for the diagnosis. Like I said, imaging is not fantastic. There are very few research projects going on at the moment. Anything that we have are looking at some biomarkers around the microRNAs. I'm involved in a research project that is looking at a novel biomarker combined with AI to try and see if we can reduce the diagnostic delay down. But at the moment, there is nothing out there. There is no evidence to support anything other than surgery and pathology then to show that it is an endometriosis lesion. And this is quite unfortunate. It's an area I think that's really open. And I would like to see a time in the future where people can maybe pop into their pharmacy and pick up a kit similar to what we have for a lot of the STI screening and bits and pieces. And, maybe run a short saliva or blood test or whatever it happens to be, and maybe give themselves a good indication that endometriosis is there. And I do think we will get there. So how do we recognize endometriosis from something else? There is a bit of an overlap there with other conditions. And one of the main ones is a condition called adenomyosis, where this is where the actual endometrium does infiltrate into the muscle layer of the uterus. And a lot of women with endometriosis will have adenomyosis as well. And that overlap in symptoms can be very difficult to differentiate. The symptoms very similar. Treatments are slightly different. If you remove the uterus for adenomyosis, that is also, it's diagnostic, but it also removes the source of the pain. Now, unfortunately, removing the uterus in a woman with endometriosis is not going to make any difference. If the uterus is not the source of the pain, it is not going to make her feel better. Removing her ovaries is going to be the same issue. It's not going to make her feel better. And Elaine is going to talk more about the hormonal treatments and the suppressions and bits and pieces. But it is it had always been assumed that if you forced somebody into a very low estrogenic state through pregnancy, through menopause, that you would influence this disease. And we now know different. We now know that, thanks to the lesions themselves, it can create their own estrogenic environment, thanks to low, levels of estrogen within the body anyway, circulating from fat cells. Endometriosis does its own thing. It'll continue on. So all those women who were gaslit after they were hysterectomized or into menopause, unfortunately, they were right. They were right when they complained about the pain. So in terms of recognizing it, I think one of the things that was taught to me in a very early stage when I was given talks in schools was we need to look at discomfort versus distress. So if you're trying to differentiate if that person in front of you is asking for pain medication for period pain, just that very simple question, well, have you missed any important social or family events due to this pain? Are you able to get up and function, in your daily life with that pain? Could you get up and maybe make yourself, your tea or whatever around that? And sometimes you can just tease those very, very gentle questions out, and you'll find that it's very easy to tell with a good listening ear the difference between, what's commonly referred as basic period pain and then the more debilitating symptoms that come with endometriosis. So supporting those with endometriosis comes in a wide variety of ways. And Elaine's going to go into a lot more in terms of how, as community pharmacists in particular, that you can help support the community. But as everybody who's listened to this webinar tonight, we all have a huge role to play. We all have women in our lives. We will all come across somebody with endometriosis. Like every single day, I speak to people, and that could be somebody I bump into in the shop. So I think the most important thing we can do is to guide them towards accurate information. And we're both going to provide some resources for that. And that is so important, because with accurate information, you can make informed treatment decisions. So no more putting people down the road of telling them that, pregnancy is a cure, hysterectomy is a cure, or that, standing on your head in the morning, in the fog after a full moon is going to cure you. And believe me, a lot of those things have been suggested. And I think within your role as well to advise them on the appropriate use of medication. And this is a huge topic. We all know, as people living with endometriosis, we are great self-medicators, and we may not necessarily be the most compliant. So I always appreciate my pharmacist telling me off and telling me how to take my medication appropriately and correctly and at the correct times. And I have to say, I've been, indebted to my pharmacist over the years. They've always been absolutely brilliant. And one of the things, we've seen in the questions as well too, that people had asked around, non-pharmaceutical, tips, what can we do outside of the drugs and outside of the surgery and all of that? And there are lots of things, and you'll find lots of them within the pharmacy sphere as well. A lot of you will stock TENS machines, TENS, heat pads, pelvic physiotherapists, the use of self-care, the use of the HSE chronic disease self-management program. There are lots of things out there that can be used to actually help sort of, get women through this as well too. But again, it all starts with empowerment and education and making sure that they understand their condition, and then to be able to use that to find good, accurate support out there as well too. Unfortunately, when we did look at a lot of the supporting treatments within the ESHRE guidelines, there was no evidence. And it's like a lot of the things we looked for in all the treatments, including surgery and drugs, the evidence out there is poor because the research out there is very poor. But anecdotally, we have heard quite a lot from women that the self-driven treatments are often some of the things that they find most important. So that could be something like acupuncture, it could be something like diet, exercise, using ways to reduce their inflammation, ways to reduce their stress in their body as well too. So I'm going to hand you over to Elaine, and Elaine's going to take you through some of the complex side and the treatment side as well too. And when the slides are shared out, there's some references there as well too, and some guidance that sort of might help, guide you to more information and sort of help answer some of the questions as well too. So thank you very much for listening.
Thank you, Kathleen. So we'll hand over to Elaine now, who will get her slides up just in a moment. Thank you.
That was harder than it had to be.
Okay. Yeah.
We've gone all the way to the end again.
It's okay.
Perfect. They were grand.
Here.
Thanks, Elaine.
Thanks so much, Kathleen. That was brilliant and informative and covered a lot of stuff. But yeah, as Kathleen said, I'm going to cover a bit more of the pharmaceutical and what pharmacists can do. A bit about myself. Pharmacist, work for the addiction services, but also I'm an endometriosis patient and a adenomyosis patient. Would have started with symptoms in my early teenage years, suffered all the way through, constantly told it was normal, constantly told I was just unlucky, told to get pregnant from as early as 14 to treat it, and eventually got diagnosed when I was 30, so nearly 16 years trying to get that diagnosis. So yeah, that's fun. We got there in the end. So endometriosis, as Kathleen said, it's an inflammatory condition, considered a full body inflammatory condition. So you have this erroneous tissue that is grown in places where that tissue shouldn't be found. The body's immune system does what the body's immune system should do in trying to remove that tissue, which causes inflammation. And therefore that inflammation then ends up going all through the body. There may well be other causes of that inflammation, but that's more than likely the main cause. But like as Kathleen said, the research just isn't there to tell us for definite what is going on. You will find because of that inflammation, you will see patients having a whole myriad of symptoms. That fatigue that Kathleen talked about is caused by that inflammation. You get brain fog, you get IBS, you get low-grade fever. It causes a huge amount, and you'll even see some other inflammatory conditions being made worse. So myself, I would find that when my endometriosis flares, my asthma flares along with it, or vice versa. So you will see some other inflammatory conditions being made worse, and women won't always put the two together. These symptoms can either be constant, they can be around ovulation, they can be around menses. Everybody's different. It's such a wide range of symptoms with this condition. Some people might just have such a low-grade inflammation that they won't even realize there is anything wrong other than they just feel off. So, you know, not only have you got this debilitating exhaustion, you've got this debilitating pain as well. So it just causes so many issues. And there was an interesting research paper, and I should have found it for this, where they actually looked at the economic cost of endometriosis, and there's such a huge cost in women missing time off work, women not being able to look after their children, women missing time out of school, out of university. As Kathleen said, women not being able to do the career that they wanted to do because they're missing time out. So it really has far-reaching effects more than just women not feeling great. So treatments, unfortunately, there are no drugs to treat endometriosis. If you have tissue grown in a part of the body where it shouldn't grow, we haven't got any drugs that will eat that tissue away and take it away. Excision surgery is really the best thing to actually remove the endometriosis itself. but we have got some drugs that will help treat some of those symptoms, to either help women get to a point where they can get surgery, to get women to a point where maybe they can travel for surgery, or just to get people, like for myself, through university and through the first few years of a career to actually build that. So, you know, there are things out there that can help. Unfortunately, disease can still grow, can still cause further problems while you're on these treatments, because as Kathleen said, they produce their own estrogen. So they can still develop while you're on these treatments, but we can slow the development down somewhat. So what drugs have we got to treat it? Well, it's an inflammatory condition, it's a pain condition. We've got NSAIDs. They are going to reduce the inflammation, they're going to help with the pain. You do find when you're in any of the groups or talking to women, when they get prescribed things like prednisolone for other inflammatory conditions, they often say that they feel amazing for the few days that they are on the prednisolone because you've reduced their inflammation. Fortunately, we can't give prednisolone all the time for something like this, but that just gives you an idea of the level of inflammation that you get with this disease. Hormonal contraceptives are also very useful in the treatment of symptoms. You reduce the amount of hormones in the body, you therefore reduce the amount of inflammation. And you will see some surgeons will even say they will see this when they're actually going in to do surgery, that there is a reduction of that inflammation in the pelvis. It doesn't matter it doesn't matter if it's progesterone only, it doesn't matter if it's a combination pill. The main thing is, in my view, anything that the woman can tolerate that doesn't give horrific side effects, that's the one to go for. There are some research papers out there. Some of them will say progesterone only is the way to go. Some of them say it doesn't matter. So in my view, whatever works for the patient, that's the way to go. I have got a link at the end of the slides to the Faculty of Reproductive Health, their guidelines on hormonal contraception. It's very in-depth, it's very detailed. Even for doing morning and after pill consultations, it is handy if people are asking what's available. It does mention endometriosis in there too, but I don't know about anyone else, but I just like having handy little links that I can click on my phone if somebody's asking me a question. So that's at the end there. Gonadotropin releasing hormone agonists, so like Soladex, so like Prostrap. You have Cinaril, which is a nasal spray, so if symptoms are horrific, the woman can stop it straight away. Can't say I'm a huge fan of them. They basically cause the ovaries to shut down, so it's chemical castration. In other words, you put the woman into menopause. When you're actually in the groups and you're speaking to women, you don't just seem to get side effects from these drugs when you're on the drugs. I've seen many, many women complain of bone pain, brain fog, joint pain for years after stopping these medications. They cannot be used for more than 6 months because they are so harsh on the body. I have some links at the end of some other side effects of these medicines can cause, and there is good research out there now that actually hormonal contraceptives are as effective as these drugs, but without the horrific side effects. So for me personally, I wouldn't recommend them, but they are out there. Some doctors will add back therapy, so they will give HRT with them to actually help minimize some of the side effects from them. The idea is that you shut down the ovaries and then you give just about enough estrogen and progesterone to help with the side effects, but to not actually aggravate the endometriosis themselves. Gonadotropin releasing hormone antagonists, or LISA is the name, the marketing name it has. It's FDA approved. They are looking for approval in Europe. I'm sure they'll get it. Basically the same idea as the drugs above. You'll shut down the ovaries, but it's an oral tablet rather than having to get an injection. They've not been out long enough to really see how patients are actually getting on with them. So for now, there's not an awful lot I can say about them. No doubt you'll expect the same side effects. The aromatase inhibitors, very interesting. Don't see them being used a huge amount. I don't know if Kathleen see them being used, but I haven't seen them being used a huge amount. Interesting in that endometriosis lesions have a huge amount of aromatase in them. So they do produce their own estrogen. And if you actually shut that down, then in theory, it can stop the growth of the lesions. They don't come without problems. They will cause overstimulation of ovaries. So they do have to be given with something to actually suppress the ovaries, such as the gonadotropin releasing hormone agonists or hormonal contraceptions. I just talked about interest, and there's a link there for more information. There's some links in that link to papers that so I like to, if anyone's in there and they like to read these things, there you go. Danazol, I just threw it at the end. You don't see it being used a huge amount anymore because it is just not a nice drug to take, but I threw it in there for the sake of kind of trying to cover all the bases. I try not to get too much into drugs because I'm lecturing pharmacists. So the role for pharmacists that I feel pharmacists have, obviously recognizing when symptoms are not normal. So if you have somebody coming in and they're looking for Nurofen plus Solpadeine for period pain, ideally period pain should be controlled by just plain ibuprofen and paracetamol. You shouldn't need anything stronger than that. I often say to people coming in for Solpadeine or Nurofen plus for period pain, you do realize that the constipation being caused by the codeine can actually make period pain worse. Everything within the pelvis is so tightly packed together in there that if you cause constipation and the bowels then trying to get that out, you will then cause the uterus to contract harder and cause period pain. So not ideal to be given with period pain anyway, particularly not ideal to be given endometriosis. IBS, you will see patients, particularly young patients, coming in looking for stuff for IBS. I've come across loads of them in my time in community. They have often come in going, what have you got for IBS? I've used everything, I've taken everything, I've seen my doctor, I've had scopes up, down, everywhere, nothing is working for this. And quite often we turn around and go, what are your periods like? What is your cycle like? Have you any other symptoms? That things start falling into place for people. So it's worth keeping an eye on these patients as well. Obviously we have a role to play on advice around hormonal contraception. So I have that link at the end. For an in-depth look at them. Obviously, if someone comes in getting something for the first time, you do realize there's other things out there. If this doesn't suit, there's other things that you can take. Pharmacists can help, as Kathleen said, we're helping with pain management. So, someone's coming in, they're asking for Solpadeine, they're asking for Nurofen plus. What are you using it for? I'm using it for period pain. Give the, you do realize it can make the pain worse. Well, actually, I have endometriosis. Well, then we can go, well, actually, what else are you taking? Because quite often these women are taking oxycodone, morphine, other things that has been prescribed from their doctor, and they are topping up with these medicines because they are in so much pain. And it's quite important for us then to say to them, actually, you really have to be careful for ibuprofen, you really have to be careful for paracetamol. And at the end of this night, I've actually linked to the IIOP webinar, Reframing the Codeine Conversation, because it is a really, really, really good conversation on what we need to be looking for when we're actually talking to patients around codeine. I watched it last week in preparation for writing this, and it is a super good conversation. And Dennis makes a point that when we're selling the likes of Solpadeine and Nurofen plus to people, we're not really worried about a codeine addiction. We're worried about them burning a hole through their stomach. We're worried about kidney failure. We're worried about liver failure. So we need to, be getting on to these women and saying, look, listen, you're taking this, that's fine, but you need to make sure that you're taking lactulose to stop that constipation, that you are not taking too much ibuprofen or too much paracetamol, and that these things are addictive, and what we can do then if that becomes an issue in the future. So yeah, that is what I feel that we can do. We can also, and I've not put this in the slides, people are asking about pharmaceutical ways of helping. So you have your non-inflammatory diet. So you can give people some advice, avoiding too much alcohol because that's inflammatory. Caffeine is inflammatory. Gluten sometimes can be inflammatory. And for some people, it's just a matter of keeping a diary, seeing what flares up their symptoms to help them prevent their symptoms getting worse. Not all the time, but it will give some relief to people. If you can find out what pelvic floor physios work in your area, it can be handy to have that link to pelvic floor, because a lot of the time when you live in constant pain, that is generated within the pelvic area, there will be muscles within the pelvic area that are super, super tight unconsciously from being in pain all the time. And sometimes just working on the pelvic floor, releasing those tight muscles, can give a lot of relief to people. And particularly after surgery, you'll find people getting some of the pain back that they had before, and it's actually muscles in the pelvic floor that have just gone like that from years of pain. So that's another non-pharmaceutical way of helping. Where you go. So then I have, like I said, I had some links at the end there to the Faculty of Reproductive Health. Like I said, that guideline goes so into depth, but it really helps. I put this in as well because I thought there was some really good information in that link. The gonadotropin releasing hormone agonist, that's a mouthful. There was some research not that long ago that said that actually men who were treated with them for prostate cancer did have an increase in vascular dementia. This hasn't been looked into in women at all, but this is worth considering as well before these drugs are used. These two links then give some information on the fact that actually hormonal contraceptions can be or are as effective as these drugs without the horrific side effects. Oh, there was one other link there. There is a link, actually, you'll probably get it when... Did I skip one? No, I seem to have got. I'll make sure that's in when it's been sent out. There's a link to a podcast in my slides as well. I don't know where it's gone to. There's a new podcast recently started in the summer called I Forgot to Ask My Doctor. She actually does an interview with Eddie Osagi, who is an endometriosis specialist working out at St. Mary's in Manchester. And he gives a really, really, really good podcast and very simple, easy to understand language for patients. All about endometriosis, how it happens, how we treat it, and he gives some good information on surgery and what to expect. So that's a really good listen as well. I'll make sure that's on the slides that Audrey has been given. And that is me, I think.
Thanks, Elaine. That's great. Thank you. So thank you both very much, Kathleen and Elaine, for your presentations. If anyone has any questions, please do type them into the chat box and we can see about answering them. So I suppose maybe to get the ball rolling, I have lots of questions they're coming into my head, but maybe the first thing on a very practical viewpoint, if we have maybe a young woman or maybe a slightly older woman who's presenting to us recurrently into our pharmacy requesting codeine containing drugs, I suppose how do you think is the best way to approach her in terms of encouraging her to go to the GP? And obviously that can present its own difficulties as well. Do you have anything that you have found particularly helpful, or anything you've come across over the years that you think that we can do to help encourage young women to go about, I suppose, advocating for themselves and helping themselves along the journey a little bit?
I think the main thing is validation. Just having another healthcare professional turn around and going, hey, this isn't normal. You shouldn't be in that level of pain every single month. It might be every second month. It might be every third month. But anyone who is in a huge amount of pain with their cycle, that is not normal. And just having someone just turn around to you and say, that's not normal, you need to get that seen, could be enough for someone to just push their doctor a bit more and go back to them, go, no, I'm sorry, but this is not normal. I want a referral to a gynae. But just that validation is massive to people. It's huge. I think I remember the first time anyone actually took me serious and said it was possibly endometriosis. I think I left and cried, because I'd been told for so long, it's normal, it's normal, you're just unlucky, you have low pain threshold, blah, blah, blah. And none of that was true.
That's true. The validation is very important. And I think, you know, for a lot of people as well, to signpost them to accurate sources of information that they can take with them to their GP, because often they've been dismissed. On average, women see 9 GPs before they have a diagnosis. So it can be a case that they may just need that little bit of encouragement to maybe say, look, you know, maybe track your cycle over a couple of months, take your symptom diary with you, or an app if you use an app, and, you know, maybe sit down and have your summary sheet ready. You know, just 3 or 4 points on a sheet, and maybe sit down and have that conversation with your doctor. But again, that encouragement of having a healthcare professional believe what they say it's worth gold. Like Elaine, I can't emphasize how important that is, to be actually listened. And I've been there, I've been at the counter, and I've explained my symptoms, and to hear that back being validated is huge.
Thank you. We have a question in about advice on a teenager describing endometriosis like pain. I mean, I suppose one of the difficulties we have with younger teenagers maybe is establishing what a normal menstrual cycle looks like for them. It might be irregular, and there are, I suppose, lots of issues in maybe getting started and putting together a picture of something being outside of a normal spectrum menstrually. Do you have any kind of views on that, on how we can help identify and refer patients like that on?
I think for me, just it's if they're missing out on really, really, you know, strong societal things that they would go to, and especially for teenagers, if it's something with their friends that they're willing to give up and miss due to this pain, that's a red flag. And you'll soon learn to know the difference between period pain and something that's a lot more severe. There's a lot more goes on with it as well too. Like there's the body pain, maybe the low grade fever, the flu-like symptoms, things like that. Sometimes just sitting down and teasing out those symptoms, I think, can sort of help differentiate a wee bit. But Elaine, you had something else there you were thinking?
I've just, when you read a lot of what you said, I was going to say myself, but I was actually thinking as well, inflammation. That endo stomach, if you've got a young teenager and all of a sudden her stomach is blown out and she looks 3, 4, 5 months pregnant, that's clearly a red flag, because no teenager should be blowing up to that level. And I think for me, like I said, I suffered from a teenager. I was literally having labor type pains, and I've since had 2 babies, and labor was less painful. So, you know, someone turn around and, you know, saying, you know, coming home from school early, leaving school, not being able to go out, not being able to see their friends. And I mean, it doesn't always necessarily start bang on with menstruation. Sometimes it can build up over years. So someone can have normal periods all through those teenage years and get to, say, their early 20s, and all of a sudden it becomes a massive problem. So it's a matter of recognizing when something was normal or it now becomes a problem. But also if somebody is saying, you know, is on their knees saying, oh, I'm in so much pain, and looking for painkillers from an early age, there is something going on, because I don't think most teenagers would even know what paracetamol is, so they ain't going to be looking around it unless they really need it.
Yeah,
that's it. And I think, Elaine, you mentioned this as well too, if your basic pain medications are not cutting it, so your combination of paracetamol and a non-steroidal anti-inflammatory together are not cutting the pain, there's something up, you know, and that's usually is the sort of a red flag we would see in young women in particular as well. And they wouldn't be as sensitized to maybe taking painkillers as some of the rest of us are. So it's another one to watch out for.
Thank you. We have a question come through about the Mirena coil being used on a teenager suspected with endometriosis, being used on her, I suppose being prescribed for, it might be a better way of putting it. But I suppose maybe if we could widen that out and think about prescribing combined oral contraceptives or other contraceptives for a teenager, or even for slightly older women, to simply to manage this set of symptoms, or the endometriosis. That obviously they all come with side effects, and I suppose it's the balance. And I suppose, do you have a view on the balance between introducing a pharmacological agent and assisting with the obviously lifestyle and day-to-day implications of this disease?
I would be a marina coil. I would probably be avoiding in young girls, simply because it's so invasive. They've not had a lot of anybody in that area, and really oral contraception, any of the pills will be just as effective, minus that, you know, invasive surgery to actually get that in the first place. So really I would be looking at oral contraception to begin with. And I mean, it might be a case of going through lots and lots and lots of pills to find one that actually suits. I mean, I get side effects with nearly everything, and it took me years to find something that I could use that didn't make me vomit or give me migraines or get a whole host of other things, or even just make me cry every night. So yeah, if it was me and it was my teenager, I would be looking at going through every pill on the market to find something that suited her. And that's why I put that link to the Faculty of Reproductive Health, because they put together some really, really, really informative and really good kind of guides on what to use. And I believe there is something in there on what side effects you're getting and what can be used instead. Because I used to have a great link years ago and I couldn't find it. And it was like, you know, if you get headaches, that's estrogen, so you need to go with something that has more progesterone in. If you're nauseous, I think that might have been a progesterone one, so you might need more estrogen. And I had it and I couldn't find it at all and it would have been a great one to put up for this, just to help people pick out, because otherwise it's just a matter of being meeny, miny, mo and picking one out. But there is a way of picking things out based on the symptoms people get, but I couldn't find the link, unfortunately.
I think one thing we need to just be, you know, very conscious of is demonizing the hormonal treatments. And I know we've seen a lot of patient groups that, and this is, you know, through our advocacy work as well, like we are saying to people, hormonal treatments don't treat the disease. They can alleviate the symptoms, but it's important to remember that, you know, be it the Mirena coil or be it the oral contraceptive pill, you know, like I credit the Mirena coil with saving my life. I had such severe menorrhagia. And like I was standing at a cut-up bench in histology with blood pouring out of me, unable to do my job. So it was like end my job, end my career, end my life. And I was fortunate, but I had to travel to the UK to get my Mirena fitted because it was refused in Ireland. So I think we have to look at all the treatments that are out there as tools. And I'm a real big fan of the 1% theory. You know, you use everything together to get you through, and be that something like, you know, maybe going through a couple of different versions of the pill or whatever it is, combined with all the other things. Because even with the best surgery and the best surgeons in the world, you are still going to live with endometriosis. It's still going to be there, you know, in its systemic form. And you may need a combination of things throughout your life. So it's always good to keep an open mind, I think, on that, even in young women.
Thank you. A question about, do the symptoms diminish with menopause?
Oh, this is the $1 million question. It was assumed that once, you know, the ovaries had stopped functioning, that endometriosis would just shrivel up and die, and that would be the end of it, and we'd have no symptoms. But we're seeing now, and that's thanks to the very brave women speaking about it after their menopause, that symptoms persist. And we have women who have been diagnosed after their menopause as well too. The oldest woman to be diagnosed, I think, is in her 70s, and that was her initial diagnosis. So some women are very fortunate, same as with pregnancy, and the symptoms can, you know, subside a little bit, and, you know, they may get some relief from that, and that is great if that happens, but it's not a given, it's not certain. And given the aromatase activity again in those lesions, you've got that local inflammation. You've also got maybe a lot of, you know, organ deformities, adhesion formation, a lot of, you know, fibrotic tissue as well too, that's going to cause that pain, and that doesn't necessarily go away just because the hormonal stimulation is gone. So very similar to pregnancy and menopause. Some people go through a horrendous time. For some people, it does give relief. So it's very individual.
I think to add to that as well, this is a disease where you've got tissue growing where it shouldn't be growing. And depending on where it's growing, I mean, for example, mine was in the uterosacral ligaments and sat on all the major nerves going into my leg. Menopause or putting me into menopause with drugs was not going to take that pain away, because it was still going to be sitting on those nerves. So it does depend on where the lesions are based, as to whether once you go through menopause and the inflammation is gone because the hormones are gone, potentially you could go on and not really suffer with your endometriosis again, or you could still have the pain, as Kathleen said, into your 70s, because it's that where it's causing pain.
We have a question about developing it slightly later in life, like maybe into their 30s or after pregnancies. And I suppose maybe that's an initial presentation of symptoms, maybe is what's being asked there. Can that happen, or have you come across cases like that?
Of course it can happen, because this is like with any disease, it's syndrome. So, you know, where one person, there's been cases of women who do not realize they have endometriosis until they go for fertility treatment. And then when they go for fertility treatment, all of a sudden, oh, you have endometriosis, and that's what's causing your infertility, but they may never have had symptoms or very obvious symptoms before. And so, yeah, it's quite possible to get all the way into your 30s and all of a sudden then these symptoms pop up. And there is a theory, there's a lot of theories on what causes it. One of the theories is that you're actually born with it, and it happens when the baby is actually being developed in the womb. So you come out with it, and then when you start menstruating, the hormones then start feeding it. And again, depending on where it is, you could go on for a very long time and it never actually make any issues whatsoever for you, or other people could have pain from the time they start the menses. Some people could even look back and go, oh, I had pains in my stomach as a small girl. Possibly that was some endometriosis that was just causing issues before anything had started really developing. So yeah, it's a funny one in that it's a lot of different symptoms, but a lot of different times for it to present itself.
Thank you.
We still don't understand the triggering event. For many, it is the onset of puberty and the onset of periods. But for some women, it can be any sort of other triggering event. Sometimes it can be post-pregnancy, you know, when the whole landscape changes. But I certainly think from a lot of the research that's out there, we are looking at the embryological theory, and we have evidence in stillborn fetuses where postmortems have shown the presence of endometriosis tissue in, you know, like in autopsy, like, so there's very good evidence to support that, and it would make sense in the grand scheme of things as well too, when you look at where the condition can end up as well.
Thank you. I think in the interest of time, we have lots of questions coming. This topic has generated so many questions, but what I'll do is put those together and put them up as footnotes after the presentation. So I could ask Elaine and Kathleen to address those maybe in writing afterwards, and we'll post that along with the slides for the presentation. I think that might be the best thing to do, because I don't want to keep anyone longer than we had promised this evening. So if you do any other questions that you want addressed as in our follow-up, please do just type them in now, and we'll address them in the follow-up to the webinar. Thank you. So Audrey's about to pop in a feedback survey. If you could complete it, that would be much appreciated. And then it just leaves me to advertise our next webinar event, which will take place in a few weeks' time. So just bear with us. So as always, we'd encourage you to complete a reflective cycle on this webinar this evening. And obviously we realize that it's a topic that's hotly discussed at the moment. So it's timely perhaps to do some learning on this. So our next webinar will take place in 2 weeks' time on the 26th of October, and that will be looking at medication management for patients with intellectual disabilities. And we have 3 speakers for that: Maura Dwyer, Juliet O'Connell and Bernadette Flood. And so do keep an eye out through Twitter, LinkedIn, Instagram, and invitations as well through your email if you are interested in signing up for that. So that just leaves me then to thank our speakers very much. Elaine and Kathleen, thank you so much. This has been a long time in the planning, and I'm so delighted that we've managed to get here this evening. I'm really delighted this topic is being discussed as widely as it is, and we very much appreciate your time and effort in putting together the presentation this evening.
Thank you.
Thank you very
Thanks,
much.
everybody.
Thanks.
Yeah, thank you.
Good night, everyone.
Thank you.